Welcome to 10 Minutes with Harry. The most common error I find with Holter monitoring with technicians is that they have great difficulty differentiating Wenckebach AV block from non-conducted atrial ectopics. Actually, it's quite simple in the vast majority of cases to be able to differentiate it, but nevertheless, difficulties come because the eye does not pick up the differences between the two. So what I'd like to do today is to explain to you the footprints of both Wenckebach AV block and non-conducted atrial ectopics and use those footprints as a means of very rapid differentiation. Let us now look at a Wenckebach AV sequence and a non-conducted atrial ectopic. In both, you can see that there are dropped P waves and that there are pauses. Then they look very similar. Then how do you tell the difference? Let's look at the ECG footprints of an AV Wenckebach sequence. There is, as you can see on this, a sequence of 3 QRSs and 4 P waves. There is a progressive prolongation of the PR interval culminating in a non-conducted P wave. So you can see the AV node progressively fatigues 210, 380, 540 milliseconds, and then there is a non-conducted P wave, an AV block. The AV node then relaxes, rests, and then starts to conduct again with the short PR interval of 210, which was seen at the first PR interval of the Wenckebach sequence we just showed. I like to say that there is an absolute footprint with Wenckebach AV sequences. That is, the longest pause is before the drop beat, then the shortest pause is after the drop beat, and therefore we can now see that the 3 things we look for are the longest PR interval and the shortest PR interval. What about the non-conducted atrial ectopics? Well, let us start with a conducted atrial ectopic to understand what is going on. You can see on the left-hand ECG, the PR interval is normal, whereas on the right, it's prolonged. This is because the P waves actually occur at different intervals, and on the right, it is partially, AV conduction is partially refractory. Have a look now at the P of the ectopic in relationship to the P of the sinus beat, and you can see that on the normal, with a normal PR interval, it's long at 320 milliseconds. However, if it now becomes a little shorter, and on the right you can see it's 640 milliseconds, then AV conduction is still partially refractory. So if we then extend that even further, we can understand why non-conducted atrial ectopics occur. So the footprints of a non-conducted atrial ectopic, very important this, is that the P wave is now premature. The P wave is usually different or abnormal in comparison to the sinus P wave, and the PR interval before and after the block beat are the same. Now let's have a look at conducted and non-conducted atrial ectopics. You can see that the P waves are inverted and from a low atrial focus. The first on the left is conducted, whereas the non-conducted one you can see on the right. Let's have a look at that distance between the sinus P wave and the ectopic. And you can see it's 960 milliseconds and allows normal conduction. But if it's only a small amount less of 860 milliseconds, now the AV conduction with the ectopic is totally refractory. You note that there is a junctional escape beat there, which is often what happens when we have bradycardia, particularly at night, and a junctional escape beat comes before the P wave emerges. Here we have, therefore, an obvious non-conducted atrial ectopic. It can be seen at the end of the T wave, but not all of them are, and some are concealed. And we refer to this as concealed non-conducted atrial ectopics. These, again, will depend on the prematurity of the atrial P wave, and you can see now that there are two non-concealed, but there is a concealed one at the beginning. And this, you can see, is in fact an atrial bigeminy of 3 beats. The first is concealed within the T wave, then we have 2 non-concealed, and it goes back to normal PR, normal sinus rhythm without ectopics. The pause, and we have non-conducted atrial bigeminy. One thing that we should note on this ECG, which we occasionally see, but is not usually identified, is there is repolarization of the P wave. So following the non-conducted P wave, there is a dip in the baseline, and this is actually repolarization of the P wave and is actually the T wave of a P wave. Have a look now at non-conducted atrial ectopics with bigeminy. The first one is conducted, and then the remaining ones are not conducted. But you can see that they lie within the T wave, and it's quite obvious that this is atrial bigeminy, of which most of the beats are not conducted. Think of a differential diagnosis, because now we have a sudden pause, and we can have something like this, where this is, we can see here what looks like and what most people would call 2-to-1 AV block. But is it? 780 milliseconds is the distance from the sinus P wave to the ectopic, and 860 to the next sinus. So this beat is premature. It is smaller than the normal sinus beat, the normal sinus P wave, and therefore this, although it's mimicking 2-to-1 heart block, it's almost certainly non-conducted atrial ectopics. There is an interesting phenomenon that when you do get 2-to-1 AV block, there is a shortening of the P to P interval, which carries the embedded QRS, whereas the P to P interval without the QRS is longer. So this actually occurs with 2-to-1 block, where it occurs and appears to be premature. The reasons for this are somewhat complicated, they're physiologic, and they are related to the cardiac output. When you have a cardiac output from the embedded sequence of P, QRS, and the next P wave, that cardiac output is much larger than, of course, the one which does not have a QRS, where there's no beat. And what happens then is that the P to P interval lengthens to 800 milliseconds, because it looks at the embedded one and says, okay, the output is satisfactory, I'll slow down. But once you have a BP interval without a cardiac output, it then says, sorry, I must get faster again. And this is called ventricular phasic sinus arrhythmia, meaning that it is sinus arrhythmia, but it occurs because of the phases of the ventricular output with 2:1 AV block. So the ECG I showed previously, which we thought was atrial ectopics, remember this phenomenon can also occur with 2:1 AV block. However, non-conducted atrial ectopics can mimic sinus bradycardia. Most people looking at this ECG would have no doubt that it's significant sinus bradycardia. But if you follow the tracing, you can see that now we have conducted atrial ectopics, which are marginally later, and as a result of that, conduct, and you therefore, when one sees these bradycardia pauses with a P wave that we may miss, then you know that this is non-conducted atrial ectopics and not sinus bradycardia. So both Wenckebach AV block and non-conducted atrial ectopics are common findings on the Holter monitoring, and both depend on the AV refractory periods. Remember, atrial ectopics occur very commonly in everybody, and Wenckebach AV block is also common, particularly in the young. So it is not surprising that they can occur together. Here is a same tracing and only a short period between them. On the left is a clear-cut Wenckebach second-degree AV block, whereas on the right, it's a non-conducted atrial ectopic. So in summary, Wenckebach AV block sequences, the PR interval is longest immediately before the drop beat. There's a non-conducted sinus P wave. The PR interval is shortest immediately after the drop beat. Whereas with non-conducted atrial ectopics, the P wave is premature, the P wave is usually abnormal, and what is critical is that the PR interval before and after the block beat are the same. So now you should be able to look at an ECG instantly and tell the difference between Wenckebach AV block sequences and non-conducted atrial ectopics. And once your eye becomes adjusted to it, particularly in looking at the PR intervals before and after the block beat, there should be no problem differentiating between the two. Thank you.